Good afternoon, everyone. Thank you for being here. I imagine many of you are as jet-lagged as I am, and it's great to see you here and awake. Before I begin, I'd like to acknowledge my many co-authors, one of them who is here in the audience, Lee. Also to say that the data I'm going to be presenting on today comes from a collaborative implementation and funding effort. So it's the effort of many groups in these 6 countries. So just wanted to start out by saying that. So how many of you are wondering why there's a presentation on stigma in a health system strengthening session? It's okay, you can raise your hands. So I wanted to start by sort of talking a little bit about why stigma in health systems. I think this is a little bit of the unusual in this kind of a session. And maybe if we start by thinking about the WHO health systems building blocks and looking at how stigma is directly related to 3 of those 6 building blocks, in particular, service delivery, health workforce, leadership, and governance. So, for example, if you take service delivery, key tenets of that building block are quality, demand for care, access, uptake and retention, and equity. And we know that stigma and resulting discrimination undermines each of those things. Therefore, it's directly related to that building block. Similarly, for health workforce and leadership and governance, we know these are things that can either drive stigma or can be undermined by stigma. So stigma is a very fundamental tenet of health system strengthening, even though we don't often think of that. And what I'm going to be doing today is showing some data that helps think about this in at the health systems or at the health facility level in kind of a very practical way to show you how parts of the health system actually can drive or mitigate stigma for clients. So health systems factors can cause stigma, and we'll be looking a little bit at that with the data that I'm showing. But just to give you an example, in a recent review of barriers to HIV testing in sub-Saharan Africa, Musheke et al. Show very clearly that perceived lack of confidentiality and poor attitude among health personnel, which is part of service delivery, was a critical barrier to uptake of HIV testing. On the flip side, health system factors can moderate stigma and its negative influence on key health outcomes. So again, in a recent review by Katz et al., and they were looking at the relationship between stigma and adherence, and they found that stigma has a very negative influence on adherence, but that the health system could actually help moderate or alleviate that relationship. So by having compassionate providers, supportive clinical environment for patients, you can actually moderate the negative effect between stigma and adherence, so stigma within healthcare facilities and also externally. So just to sort of ground us in why we're listening to about stigma in a session on health systems. So what does stigma look like within health facilities? I don't have the time to go into a lot of detail, but I just wanted to sort of give you a flavor of what this actually looks like in a health facility. How does it manifest itself? The first thing, and I raise this first because this is what we're going to be looking at in the data, is what we call stigmatizing avoidance behaviors. So often in health facilities, you'll find that staff will use certain selective use of gloves, for example. So they'll use gloves to take the blood pressure of a patient living with HIV, but they will not do that for someone who they assume is not living with HIV. So you have selective use of sort of avoidance behaviors driven by fear of HIV transmission that is not only stigmatizing for the patient, but also leads to breaches of confidentiality, because it means that anyone who is witnessing this behavior knows that this person is different. And so it can lead to disclosure of this person's HIV status. So that's one form of stigma that happens in the health facilities that we need to be aware of. Other things that go on are outright denial of service, lower quality of care in general, breaches of confidentiality that happen in different ways, verbal abuse, and gossip. Health care providers themselves can also experience stigma. We call it secondary stigma or stigma by association. So they may experience stigma from their colleagues, from their families, from their communities because they work with people living with HIV. So what drives stigma in health facilities, and what can we do to actually reduce it? There's been a lot of work over the past 10 to 15 years on stigma in healthcare facilities, both on sort of describing it, on quantifying it, and also on how to reduce it. And what we've learned from that is that there's 4 actionable drivers of stigma in healthcare facilities, things that we can get a handle on right now and do something about. The first is lack of awareness of what stigma is and what it does. We all stigmatize, and it's often unconscious. We're not aware that what we do is actually stigma. So simply having a program that helps people understand and become aware of what actually is stigmatizing. So for example, many healthcare workers who put on double gloves when they're working with a patient with living with HIV don't understand that that is actually stigmatizing and has negative consequences. So a simple program that actually helps create that awareness can have a huge effect. Attitudes and opinions, whether we like it or not, it often drives the way we deliver services. And then worry about HIV transmission on the job. There's still a significant amount of worry in the general population, but also among healthcare facility staff. And this can be a driver, particularly of those stigmatizing avoidance behaviors that I just described, and which you'll see in the data that I'm going to present. And the last thing is the actual health facility environment itself. Are there policies? Are there supplies? Is there support for staff to provide stigma-free services? And I've bolded these last 2 because this is the small piece of the puzzle that we'll be looking at today with the data that I'm presenting. So before I actually present the results, I just want to give you a little bit of background on where the data comes from and what our key questions and methods are. So as mentioned earlier, this was a collective global effort, and it was developed to actually develop and field test a brief questionnaire for measuring stigma and discrimination in healthcare facilities that could be standardized across very different contexts, and that would be brief enough that it could actually be used in health facilities, opposed to a lot of the gold standard measures that we have from research that are really too long to be practical in using in health facilities. So we had a group of stakeholders that came together, put together a questionnaire. This was then field tested in 6 sites in these countries. It was both self and interviewer administered. It included a range of facilities. This varied a bit by site. It included both clinical and non-clinical staff. And this is important because we know that stigma in health facilities can start at the gate with the guard. It can include the registration desk, and sometimes that's enough to drive a client away before they even get to the health provider. The ends ranged from 300 to 350 per site, and the total sample size was roughly 1,900, and it was 72% female, reflecting the gender balance in most health facilities. So what are the key questions we're going to look at with the data today? The first is, what is the relationship between facility environment, so these are our health system element here, and worry about infection on the job? And I'll talk a little bit about how we measure that in a moment. And the second question then is, what is the relationship between worry about HIV infection on the job and self-reporting stigmatizing avoidance behaviors? So as I had mentioned earlier, this is a form of stigma that occurs in healthcare facilities, and so we're looking specifically at that. We looked at both we started with the bivariate relationships, which I'll not present here today, and then what I will present is the multivariate logistic regressions adjusted for background characteristics. So I'm going to quickly run through some of the frequencies and to show you how we actually created and measured our key variables. So for the health facility environment, we used 3 variables. One was self-report that my facility has availability of post-exposure prophylaxis, that my self-report that my facility has standardized procedures and protocols that protect me from workplace HIV transmission, and self-report that I feel like I have enough adequate supplies in my health facility to protect myself. So these 3 items make up our health facility environment variable that we're looking at today. And for the regression analysis, we created a composite indicator. So we put these three together, and we are looking at the difference between reporting that you had no support on none of these items or one of them, compared to support on 2 items and support on all 3 items. So those people who are reporting support on all 3 items are those who feel they are very protected from workplace transmission of HIV. The stigmatizing avoidance behaviors that we measured, there are 4 of them. We create a composite indicator, which is that agreement on at least one of these 4 items. So as you can see, a little over 71% report, and this is self-reporting, that I routinely use one of these measures when I work with HIV patients. So this is a respondent saying themselves that, yes, I do this on a routine basis with clients who are living with HIV. So you can see 71% are reporting these behaviors. We then looked at worry about acquiring HIV in job functions. And there we had a long list of different things that can happen in the health facility that might be done, including things that have absolutely no risk of HIV transmission, like taking someone's temperature. I thought I only had 10 minutes, so I didn't present that data. But we also looked at these relationships around fear, both with this category where there is some potential risk of HIV infection and those where there is no risk. And I'll just tell you that the relationships hold for both types of activities. So again, we created a composite indicator. So basically, if you express that you had concern or worry about acquiring HIV when doing these things, and you'll see close to 67% of our respondents said that they had some worry when doing these three things. So now we'll turn to the logistic regression results. So this is that first question I talked about, where we want to look at the relationship between our health facility environments and worry, expressing worry about contracting HIV and doing certain activities. If you focus on the bolded number at the bottom, this is kind of the main result, and these are odds ratios. So what this is saying to us is that those people who report that they have support on all 3 items, so they feel like they're really supported to be safe in their environment, have odds ratios that are roughly 50% lower than those who report that they have support on none or 1 item. So the bottom line is, those people who say that they are fully supported are much less likely to report that they have fear of HIV transmission in their daily activities. So now turning to the second relationship that we looked at, this takes that worry variable, so expressing worry about potentially being able to have HIV, contract HIV when doing these activities, and these stigmatizing avoidance behaviors. So self-reporting that these stigmatizing avoidance behaviors. And again, these are odds ratios, and if you look again at the bolded number at the bottom, you'll see that respondents who expressed worry, so they were afraid that they could contract HIV while doing these activities, have odds ratios that are 1.88 times higher than those who had no worry. So people who have worry in health facilities are much more likely to engage in stigmatizing avoidance behaviors. So what does that mean? Where does that leave us? What's the conclusion about that? The conclusion really, and this is just one very small illustration of how this works, but that stigma matters to health systems and health systems matter to stigma. So health system factors, in this case, policies, procedures, availability of supplies, can either drive or moderate stigma that's occurring in the healthcare facility. The healthcare facility environment influences staff worry, and worry in turn is related to stigmatizing avoidance behaviors. And these are detrimental not just because they're stigmatizing, but also because they can lead to breaches of confidentiality around people's HIV status. And then just to add more generally that stigma can undermine health systems. We know particularly in the areas of quality of care, access, and equity. And we also know that it has a detrimental effect on health outcomes, particularly on uptake of HIV testing, linkage to ART care, and adherence, all things that our health system is trying to make happen. So where do we end on this? I'd like to end with the message that action is possible. How can we work on stigma as part of health system strengthening? The first thing we can do is make stigma an explicit component of quality. So I think we had a previous speaker who talked about the quality improvement. So how can we incorporate stigma reduction into those quality improvement processes? How can we include stigma indicators into quality assessments? We can do this also by incorporating stigma reduction into training, for example, licensing and accreditation for both individuals and facilities, performance assessment, supervision. These are just some of the ideas. And most importantly, to ensure that guideline standards, policies support provision of stigma-free services in health facilities. And the good news is that we have really good stigma reduction tools and measures for facilities now. There's been a lot of work done in the past decade, and so the tools are there to actually make this happen. We have participatory stigma reduction training materials. We have an administrator's guide that's going to be coming out soon, and there's standardized measures and approved indicators that actually came out of this work. In May, the UNAIDS Monitoring Evaluation Reference Group approved 6 indicators for measuring stigma in healthcare facilities. So the tools are there for action. Thank you.